Bismillah ar-Rahman ar-Rahim. Today we're gonna discuss how to pick up plasma cell dyscrasia. I am Mohammed El-shazly. I'm a lecturer of Hemato-oncology, bone marrow transplant, and cellular therapy in Alexandria School of Medicine. So discussing plasma cell dyscrasia is a bit confusing for most. Why is this? As we can see the lot of balloons or circles over there, it's basically a spectrum of diseases that usually overlap, as we can see over here. It is made of a spectrum of diseases, as we discussed, from multiple myeloma to monoclonal gammopathy of undetermined significance, to amyloidosis, to solitary plasmacytoma, Poems cryoglobulinemia, Waldenström. So basically, we need just to untangle this. The classification of the plasma cell dyscrasia, as you can see over here, together with the incidence, 62% is made from the monoclonal gammopathy of undetermined significance. Or in 18%, we can see multiple myelomas with its variants, with the smoldering myeloma, the non-secretory myeloma, indolent and light chain. Plasmacytoma constitutes around 2.5%, which is usually arises from the bone, or extramedullary and extraosseous plasmacytomas. Plasma cell leukemias, IgD myeloma, Poems syndrome, and Waldenström macroglobulinemia. Also other malignant lymphoproliferative disorders, heavy chain disease, or immunoglobulin deposition disease. So when to suspect myeloma? Defining active myeloma has been changed recently according to the recent diagnostic criteria published by the International Working Group of Multiple Myeloma, and the paper was published in the Lancet Oncology in 2014 by Vincent Rajkumar, who is mainly the godfather of the myeloma. And it constitutes from the CRAB criteria, the calcium elevation. We know the synonym, of course, the CRAB synonym, and it has we have added on it the SLIM criteria. The CRAB from the hypercalcemia, renal dysfunction, anemia, and bony lytic lesions, which is found on X-ray, CTs, or whole body PET scans, and added on them is the SLIM criteria recently, which is the 60% bone marrow plasmacytosis, light chain, which increase in the ratio between the HAVE and the light chain, and the ratio needs to be in excess of 100. And one of them has to be elevated more than 1 microgram per deciliter. Or on the MRI, on the whole body MRI, to have more than one focal lesion. So the diagnosis of the multiple myeloma, it has many tests so that we can confirm the myeloma or the presence of the plasma cell dyscrasia and evident clinically evident myeloma in the patient. So we have initial tests that we can run from the CBC, the albumin, calcium, creatinine, electrolytes, and urea and nitrogen. And we have the confirmatory tests that we do to confirm the screening tests initiated above. From the 24-hour urine protein, beta-2 microglobulin, LDH, both of these we use them in the what we call international staging system, or the ISS stage, or the revised ISS stage. Also the serum free light chain, serum immune fixation, serum protein electrophoresis, quantitative immunoglobulins, skeletal survey, which can be used by various methods, urine immune fixation, urine protein electrophoresis. Also, other tests, which is more sophisticated or more confirmatory, or mainly to classify the type of the myeloma. We have the bone marrow aspirate biopsy, together with the cytogenetics, flow cytometry, and the fluorescence in situ hybridization or immunohistochemistry that usually we do in order to classify and define the myeloma. Other tests indicated in special circumstances that we may do for the bone densitometry, the PET-CT, or the whole body MRI, serum viscosity, and we will discuss, this is of special interest because usually we do this in the Waldenström tissue biopsy or the cryoglobulinemia tissue biopsy of any site of the plasmacytoma. To discuss the differential diagnosis, or how can we differentiate the multiple myeloma from other disorders that may be encountered, or it may confuse us with the CRAP criteria. So we have malignant and benign disorders. Discussing the benign disorders, which really may be confusing with the multiple myeloma, with the autoimmune disorders, infectious diseases, and post-transplant effect. But mainly we need to differentiate the multiple myeloma from other malignant plasma cell or B cell disorders. From the plasma cells, we need to discriminate or differentiate between the multiple myeloma and the MGUS, also smoldering and amyloidosis, which is basically simple in the hands of experts. As we can see, in the amyloidosis, usually if the patient is running extensive GI effects or cardiac effects, or the thing that is very diagnostic, the peripheral neuropathy or the affection of the peripheral nervous system, usually we need to suspect the amyloidosis. In the smoldering multiple myeloma, usually it is a clinical effect. I'm sorry, it's not clinical effects, it is laboratory differentiation, which may be done, and we will discuss it in a couple of minutes. And again, MGUS also, usually the patient is not running any disease, just like the smoldering myeloma, and it is considered a precursor diagnosis. From the B cell disorders, we have the lymphoplasmacytic or the Waldenström macroglobulinemia, which we will discuss also in the forthcoming slides, the CLL, SLL, or the marginal zone lymphoma, or the other indolent lymphomas. Differential diagnosis, as we said, between the MGUS, smoldering myeloma, and symptomatic myeloma is basically done when we do the bone marrow aspiratum biopsy and the serum monoclonal protein. So basically, the patients for the MGUS and smoldering myeloma, or the main differentiation between the smoldering myeloma, MGUS, and multiple myeloma is that multiple myeloma, the patient is running a clinical disease. But for the MGUS and smoldering myeloma, the patient is not running any clinical disease. Together with the bone marrow, the plasma cells in the bone marrow for the MGUS is usually less than 10%. In the smoldering myeloma, the plasma cells is usually more than 10%. Also in the multiple myeloma, and for the paraproteinemia or the M-band or the abnormal protein that is released due to the presence of the multiple myeloma in the body, or what we call Bence-Jones protein, it is less than 3 grams for the MGUS, and it's more than 3 grams for the smoldering myeloma. So taking up a notch on the pathogenesis or the pathogenomics of the multiple myeloma, we need to know how the multiple myeloma disease progresses, and basically the drivers of the clonal evolution of the plasma cells from the bone marrow, which is affected by the clonal competition and the tumor microenvironment. Also the treatment and the immune system. Usually it arises from the post-germinal cell, B cell. It starts off with the hyperdiploidy and the IgH translocations, which progresses these peculiar type of cells into the monoclonal gammopathy of undetermined significance, and then usually these cells start to pick up other mutations, which progresses the disease more, mainly due to picking up of KRAS mutations, MYC activation, genomic instability, and TP53 mutation, which usually also shifts the gears and progresses the MGUS into the smoldering myeloma and eventually into multiple myeloma. Basically then, it picks up secondary genetic events and the deletion of 17p or the TP53, which tips it off the edge and starts to have the clinically evident multiple myeloma together with the extra medullary disease. And this happens basically together with the tumor microenvironment remodeling, and we will discuss it further. Again, this is a cartoon displaying the progression of the germinal B-cell myeloma or the germinal center B-cell, which progresses or initiates the plasma cell dyscrasia spectrum. The progression that we can see from the MGUS to the smoldering myeloma in the intramedullary and the extramedullary, and then having a medullary cell line. We usually have a primary immunoglobulin translocations. Then it usually picks up the secondary immunoglobulin translocation together with the famous 13q14 deletion monosomy translocation, which may occur with the activating mutations of the NRAS, KRAS, and FGFR3, and eventually picking up the TP53, which is the most serious or the most fatal form of mutations that we can pick up in the oncology in general. It is involved in a lot of the malignancies that we see on daily basis, which usually turns the disease fatal because these genes are called the caretakers, and they are responsible for the repair of the genetic mutations that may occur on daily basis. And as you can all know, of course, it's a common knowledge that the TP53 is usually called the caretakers, and they usually are involved in the process of the repair of our genes or their translocations or the abnormal translocations that occur on a daily basis. So basically, having failure of this system, of this caretaker system, eventually turns any type of malignancy into aggressive forms and metastasizing forms of the disease. Again, emphasizing on the spectrum of the plasma cell dyscrasia, we usually have the post-germinal center B cell, which starts to have clonal plasma cells due to initiating or activating mutations in the IgH or the immunoglobulin heavy chain, and then picking up the RAS mutations, having the hyperdiploidy, which tips the post-germinal center B cell from just a normal cell to turn it into the plasma cell leukemia due to different types of mutations which occur in the course of the disease. sorry. The disease usually starts in the bone marrow with having these post-germinal center cells, which picks up the different mutations. And as you can see here, they are the different mutations that are involved. This is a very interesting paper which basically highlighted the exact translocations that occur, and together with the clinical disease that happens, and whether it's still in the bone marrow or it overfled into the bloodstream, the hyperdiploidy translocations or the non-hyperdiploidy translocations, and together with the RAS mutations, and together with the TP53 mutations, which basically aggravates or progresses the plasma cells from having just a normal morphology into having a malignant morphology and genotyping and progressing into aggressive form, which overfloods into the bloodstream. Another presentation for the plasma cell dyscrasia is the amyloidosis, which we usually suspect if we have an end organ disease from the nervous system, the heart, the kidneys, or the GIT. And we have two types of amyloidosis. We have the primary and the secondary forms, or the ATTR amyloidosis or the AL amyloidosis, which basically involves two different types of protein, the transthyretin or the light chain amyloidosis. And basically, in both of these, they involve a certain protein which misfolds and starts to form amyloid fibril formation and starts to deposit in different organs, which leads to mainly a problem in the heart and the kidneys. Both of these deposition in these two end organs usually causes a significant morbidity for the patients diagnosed with these. And we have a lot of tools now to use with the amyloid or the amyloidosis to control it and even reverse the pathogenesis of the disease. Basically, this is the progress that occurred for the light chain amyloidosis or the transthyretin amyloidosis. We have diseases to limit the light chain overproduction nowadays with the proteasome inhibitors, the IMiDs or the immune modulatory agents, novel ones with the anti-CD33, anti-CD38, like the daratumumab, the venetoclax, the BCL2 inhibitor, which limit the light chain overproduction and controls the plasma cells. Also, we have other diseases, other drugs that are involved now in the inhibition of the amyloid fiber formation, like the doxycycline, and we have other newer drugs now, even that removes the light chain amyloid deposits from the end organs, like this drug, which is a monoclonal antibody that binds to the light chains and removes them from the end organs that were deposited in them. For the transthyretin, again, we have the transthyretin synthesis inhibition drugs. We have the tetramer stabilizing agents. We have drugs that removes nowadays the transthyretin from the end organs, and it removes the transthyretin amyloid deposits from the end organs, and all of these drugs are showing a great promise nowadays in the management of the amyloid disease. Another clinical form is the Waldenström microglobulinemia, and I don't want to confuse you more, but basically it involves the IgM. It causes a Waldenström precursor memory like CD27 positive cells, which basically turns into Waldenström or the lymphoplasmacytoid Waldenström cell. These cells basically release the IgM and causes its pathogenesis. And this pathogenesis is usually very peculiar because it causes cryoglobulinemia and it causes hyperviscosity due to the large antibody, the IgM, which is released in the blood, and basically together with the rest of the manifestations of the plasma cell dyscrasia. For the diagnosis and the treatment for the macroglobulinemia is usually an indolent disease, and we do not need to intervene unless the patient is mainly or heavily symptomatic, or the patient is running HIV infection. Basically, if the patient is asymptomatic with no affection of the bone marrow, or there is no bone marrow depression signs, usually we observe these patients. But for the patients who are running into bone marrow suppression or Waldenström related neuropathy or cryoglobulinemia or having hemolytic anemia, we usually start monoclonal antibody like the rituximab, which usually suppresses the formation of the B cells. It's a B cell aplasia therapy, or do, of course, plasmapheresis to relieve the cryoglobulinemia, or the patient is having a bulky disease or profound cytopenias or hyperviscosity symptoms. So usually we start with the plasmapheresis and we give 4 to 6 cycles of bendamustine rituximab, and we harvest his stem cells for potential autologous transplant, because as all we know, the standard of care for these patients, for all the plasma cell dyscrasia patients, or mainly the multiple myeloma, the symptomatic plasma cell dyscrasia, we usually offer them auto-transplant in order to control their disease. We have the rare form, which is the POEMS syndrome, which is diagnosed mainly through the major criteria. Also, again, the other pathology that involves having a nervous system affection other than the amyloidosis. Again, we have a monoclonal plasma cell proliferative disorder, and other major criteria. One of them must be there for the VEGF elevation, sclerotic bony lesions, and the CD. Other minor criteria, the organomegaly, extravascular volume overload, and the endocrinopathy. The minor criteria, also one is required to diagnose the POEMS syndrome from the skin changes, the papilledema, and the thrombocytosis or the polycythemia. Thank you all for listening, and I know it's a challenging lecture, and we will be streaming this over the YouTube, and please let me know if I can help with the questions, if anybody has any questions.